So this project is called the reanalysis of international survey data, but in reality it's a mixed method project, and you'll see that there's also a qualitative component we'll briefly talk about at the end, where it's also a qualitative international survey that we're doing as part of Project 3. What I'll do today is to provide some very quick background about Project 3, highlighting how it fits with the impact research programs, talking about the two components of Project 3, the qualitative and the quantitative component. But today really we're mostly addressing the quantitative component by looking at these international surveys. So the second part will be about presenting these international surveys in terms of data source, and talk about the mapping that we did to the access framework, so that we identify what information could be useful to analyze and support the impact work in different projects as well as in the local innovation partnerships. I'll then proceed to the LIPS consultation. This is the final stage because you've all participated already to a great extent, but today we'll really vote for a last time on those questions, and this will be for us the starting point of the quantitative analysis, and very shortly then you'll be able to have some results. And then I'll just review what's next in terms of Project 3. So Project 3's objective is to identify contextual factors that may affect equity in access or impact the success of access innovations. And it does this by analyzing what we see in different countries in terms of barriers to access for different vulnerable populations, and by generating hypotheses about what could be the organizational or system factors that may explain more or less disparities in access in the different countries that we are analyzing as part of this survey. That's where the Project 3 fits in the overall design of impact. You all know about the Project 1, which is almost completed, where we scoped the innovations, really trying to capture what's currently happening in terms of innovations in primary care that might be interesting to replicate and implement in the different LIPS. Project 2 is on the way, and you've participated in selecting the most relevant questions for synthesis to look at effectiveness and implementation of some of the innovations that were judged as being priority for your context. Project 3 is, as I said, the mixed method analysis of surveys. We're going to do a quantitative analysis summarizing patterns of inequities and dimensions of access across jurisdictions. This is supporting case studies, engaging experts across countries to identify possible contextual factors influencing observed difference in access. And those really are contributing to all of your thinking about the innovations, how they could be implemented, adjusted to your local context, and really so that you make final and integrated decisions about what to do to try to improve access for the vulnerable populations that are a priority for your context. So it is additional to Project 1 and 2 in terms of providing information that will then support the adaptation and implementation of innovations before we move on to Project 4 in the last years of the project, where these innovations will be evaluated. So it's a reanalysis of international survey data. We're looking at international differences in different aspects of care, and we're also aiming to identify which population groups face challenges with access to primary health care across a range of jurisdictions that are covered in this international survey. The case study method, as I said, identify contextual factors and will include experts and stakeholders interviews across the jurisdictions to discuss the results of the quantitative analysis and then reflect on innovations and priorities in their areas as well. So the surveys that we're using are mostly the International Health Policy Survey conducted by the Commonwealth Fund. The Commonwealth Fund is a non-for-profit organization based in New York City in the US. They run this survey on a yearly basis, alternating different types of surveys, population surveys. The most recent one is the 55 years old and up survey. They also have conducted sicker patient surveys and primary care provider surveys. And these are the countries that are covered in the 2013 and 2014 surveys that we're interested in. So Australia, Canada, France, Germany, the Netherlands, New Zealand, Norway, Sweden, Switzerland, the UK, and the United States. It has to be said that as you can see in both the 2013 and the 2014 surveys, Australia and Canada have quite an important sample with respectively 2,200 for Australia in 2013 and 5,400 for Canada in 2013. The other countries have much smaller sample size. And that's because Canada and Australia have been particularly active at oversampling this international survey to generate information that is at times representative of provinces in Canada as well as some states in Australia. So in Canada it's mostly Quebec, Ontario and Alberta that have oversampled. However, the most recent one has got also good sampling for British Columbia. And in Australia, New South Wales has oversampled. So it's not going to be covered as part of the first analysis that we're doing at the moment, but there is information you can get that will be more specific to these provinces and states as part of the survey. And of course in the other countries there's not this capacity to go at a lower level, except in Sweden in the recent survey where they interviewed as many as in Canada. So the survey in 2013 was for adults of age 18 and older, and the survey in 2014 was adults of age 55 and older. And therefore they provide a very complementary information about potential access barriers. The 2013 survey has got the advantage of being an entire population survey, and therefore even younger people that might have more episodic or sporadic needs for health care will talk about their experience as part of this survey and identify barriers, whilst the 55 and older survey obviously considers a population that are more regular users and therefore can look into more specific aspects related to chronic disease management and other types of barriers. So those two surveys will be analyzed as part of this reanalysis that we're doing to provide this complementary understanding. So some motivation to start, however. You can see here Albert Einstein saying we cannot solve our problems with the same thinking we used when we created them. And we're just offering this quote to you to say that the access framework that we are using in Impact is different from the very restrictive availability conceptualization that access that have been used to analyze access in the past. And some of those dimensions might seem a bit less related to access, but we really feel that they are providing a complementary perspective on access that might help us to think differently about access problems, and therefore maybe would put us in a situation where we have more chances of identifying innovations that would be useful to solve these problems. So some of the questions in the Commonwealth Fund surveys might seem a bit less related to access, but as part of the framework we could identify new areas that are worth considering and looking at if we want to try to think outside the box and differently about access problems for vulnerable people. So as you know, this is the access framework. I'm not going to revise it. It has been presented to you at various times. But it's just a reminder that we are looking at those 5 dimensions today. Following up on the consultation we did with the consultation document, we'll ask you to reflect on the questions that were identified by the 6 LIPs as being priority, and ask you to restate how important you feel they are, and we will follow those 5 dimensions of access from the supply and the ability of people's perspective. So the starting point for us was to look at the survey. It's not a survey that we designed neither in 2013 nor in 2014. We had to work with the questions that were existing, and the survey was not made to analyze access either. So the questions were not organized across those access dimensions that we have in the project. So what we did, amongst a group of researchers, we did a first classification of the different questions, and I'm showing this, but I know you can't read, but each of those lines in this table represent a question, and then you can see the different colors related to the sub-dimensions of access that we attributed those questions to. And you can see that for the first 4, we all unanimously said that those 4 questions were related to affordability and ability to pay. There was some agreement with regards to the availability and ability to reach questions that we can see here, and quite a lot of agreement with the appropriateness questions, but there were also some disagreement that we had to solve, so that we would suggest to you to prioritize those questions according to those categories. It's not a perfect attribution. We can see that some questions, because of the way they're formulated, might relate to various dimensions of access, but we had to identify the main dimensions that they would relate to before going into the prioritization process. This being said, if a question is prioritized and relate to many dimensions, we'll be able, as the study goes along, to actually use this question to inform those dimensions as well, given the fact that some questions really relate to more than one dimension of access. We then send you this consultation package to try to identify with you a limited set of questions for further analysis. One of the issues that we have with this project is that, as you could see, there's a lot of questions that relate to access as part of these surveys. It's not possible for us to do a very deep analysis of all of these questions, and therefore we had to try to prioritize those that would be the most important before we engage more fully into the quantitative analysis. So what we wanted to find really was to what extent are questions a priority for each of your LIP, either because you would lack information about that aspect of access, or because it's likely to reflect a problem in the area of the LIP and therefore something important for the vulnerable population you had identified, or that some change would be expected following the innovations that are being or will be implemented in the LIP. So all of those merged together, we wanted to know which questions would be a priority for you. So this is just an example of a part of a table. This is showing the questions that relate to usual place of care, coordination when leaving the hospital, outreach and proactive actions. You can see that each of the provinces and states, with the exception of New South Wales, because we received the information from New South Wales just after finalizing this presentation, but you can see that who has identified as low, moderate, and high priority each of those questions, and for which jurisdictions that question was a top question. So to take an example, the question about one doctor, is there one doctor you usually go to for your medical care, was quite mixed in terms of priorities across jurisdictions, but was identified by one jurisdiction as being a top question. The question about having a group or center as a source of care, and the one about knowing who to contact following discharge from hospitals were much more homogeneous in terms of being a high priority, and were identified by 3 jurisdictions as being a top question. So using those tables, we selected for the webinar today a subset of questions per dimension to submit to you. highlighting out of all of these questions which ones seems to be the most salient in terms of reflecting on something important for each of the lips or across the lips. Mostly, I would say, before I go further into the presentation, that there was quite a strong agreement with regards to those top priority questions. That doesn't mean that the questions we selected will reflect all of your priorities, because you can see that there were more specific priorities across different jurisdictions. But overall, there was a certain consensus achieved for 3 or 4 questions in each of those dimensions, really being seen as important across the board. So before I go further, maybe it's a good time, Sarah, to check if there are any clarifying questions before I continue.
There haven't been any question yet, but I don't know if anybody has any question at the moment that they would like to be answered. Is the objective of Project 3 clear to everybody? So I think we can continue. I have no responses. Oh, wait.
Excellent.
Wait, wait, wait.
I'll wait.
No. The comment is just yes.
Okay.
So yes.
Excellent. Excellent. So now I'll ask you to be interactive. And as Sarah said from the start, it's the first time we're trying GoToWebinar, so hopefully I'll be able to manage it appropriately, and please forgive me if I need Sarah to troubleshoot and help me in a tough technological situation. So these are the questions for approachability and ability to perceive that were identified. So just as a reminder, approachability and ability to perceive relate to the fact that people facing health needs can actually identify that some form of services exists that can be reached and they can have an impact on the health of the individual. And obviously, various vulnerable populations might have difficulty to perceive this need, either in terms of perceiving their health needs or perceiving that some services is available and could help them, and therefore they might not even try to reach any services. For the clinics or practitioners' perspective, it's about making sure that there is an outreach perspective and that they inform their population about the services that they could benefit from as well. So the 3 questions that were identified were, is there one doctor's group, health center or clinic you usually go to for most of your medical care? The third one is, when you left the hospital, did you know who to contact if you had a question about your condition or treatment? And the third one is, between doctor visits, is there a healthcare professional who contacts you to see how things are going with your chronic condition? And what we'll ask you to do in this poll is to identify which approachability question is of highest priority for your lip, and you can select more than one option. So you could press 1, 2, and 3 if you feel that those 3 questions are important, or you could decide to select 1 and 3 only, or 3 only. And if you select 4, that means that none of these questions are a priority in your lip. And in this way you can really vote for the entire dimension and say approachability is not a big issue for us, as well as identify a more specific question or all of the questions if these are very important for you. So if you could take some time to, again, to read these questions, they will unfortunately disappear, I think, when I start the poll, but I can repeat them whilst I give you some time to vote. So A is there one doctor's group, health center or clinic you usually go to for most of your medical care? B is, when you left hospital, did you know who to contact if you had a question about your condition or treatment? And C, between doctor visits, is there a healthcare professional who contacts you to see how things are going with your chronic condition? So let's try it out. I'll give you a minute to vote on this, and then you can select the most appropriate question or answers. Sorry. So I'm launching. Here it goes. Is it working, Sarah? Yeah.
It is.
Excellent.
I think all the votes are in.
It's written 64% voted, but that's probably because we have some part of the team observing as well.
Exactly.
But maybe I can give you another 15 seconds just in case someone requires a bit more time. Seems good? Excellent. So I'll close and then share. So these are the results. I think you can probably all see them on the right side of your screen. So 80% of you said that where is there one doctor's group, health center or clinic you usually go to for most of your medical care is important. 60% voted for who to contact if you had a question about your condition or treatment, and 40% between doctor's visits, is there a healthcare professional who contacts you to see how things are going? And there was no vote indicating that none of those questions would be important. Excellent. This is working really well. I'm impressed. All right, the next one. So the next one is about acceptability and ability to seek. It relates to the cultural and social factors that determine the possibility for people to accept the aspects of the service and the judged appropriateness for the persons to seek care. So from the person's perspective, this dimension really relates to the fact that if they perceive they have a problem and they perceive that there's a service that could help them, are there any impediments, either social or cultural, that might prevent them from seeking seeking care? So for example, there might be cultural taboos that would prevent someone from contacting a medical professional from a male gender, for example. From the provider perspective, it's really about providing social and culturally appropriate services so that people have an option that would be acceptable to them if they are to seek care at a specific facility, community health center, or other types of services. And the three questions that were identified, or for which there was more consensus, were: how often does your regular doctor or medical staff you see encourage you to ask questions? So that's about involving you and treating you as a partner in care. The second one is: how often does your regular doctor or medical staff you see explain things in a way that is easy to understand? So that's about the quality of the information that's provided to inform people seeking care. And the third one is about: during the past year as a healthcare professional you see for your chronic condition, discussed your main goals or priorities in caring for this condition. And that's really about trying to tailor care to what's important for patients as part of the service. So being encouraged to ask questions, the second one explaining things in a way that is easy to understand, and the third one about discussing goals and priorities to consider in the care for chronic conditions. So the second poll, as the first one, will ask you if question A, question B, question C is a priority, or option 4, if none of them are a priority in your local innovation partnership. So I'll start again and select the new one. So I will start it right now. I'm at 54% voted. I'm going to give just a few, just a bit more time. If there's any remaining vote to be added. Excellent. I think that it's stable now, so I will close the poll and share the results. So you can see that 22% have identified the quality of the encouragement to ask questions as being a high priority. 78% medical staff and regular doctor explaining things in a way that is easy to understand as a top priority, and 56% of votes for discussing priorities goals and priorities in caring for the chronic condition. And again, no one identified none of those questions as being important. Excellent. There is a bit of conversation in the chat, I can see. Is there anything I need to address, Sarah, or should I continue?
No, it's fine. Thank you.
Okay, excellent. Thank you very much. The third one is availability. This dimension is the classic accessibility question in many conceptualization and questionnaires. But as part of our conceptualization, it also includes ability to reach. So it's not just about availability of the providers. And it refers to the fact that health services, either the physical space or those working in healthcare roles, can be reached both physically and in a timely manner. And it depends on characteristics of the service as well as ability for people to be mobile, reach the actual facilities. There are 4 questions for this one that seems to have reached a consensus in the first stage of the consultation. So the first one is, how easy is it to get medical care in the evenings, on weekends or holidays without going to the emergency? The second one is about, between general practitioners' visits, is there a professional you can contact to get advice about your chronic condition? The third one is, when you call your regular GP's practice with a medical concern during regular practice hours, how often do you get an answer that same day? And the fourth one is about, when you feel emotionally distressed, were you able to get help from a professional? It has to be said for the fourth one that it of course only relates to those people that will declare having felt emotionally distressed, and therefore the sample size in many of the jurisdictions is much smaller for this one. And that's a limitation that you need to be aware of. But there was a clear consensus about the importance of this question as well as for question A, B, and C. So A is about being able to access care outside of usual hours. B is about ability to contact someone for a chronic condition between visits. C is about being able to get an answer on the same day if you have a concern with regards your care or medical condition. And D is about receiving help for emotional distress. So the poll is slightly different. There's 5 options, but the first 4 are, of course, for the importance of specific question A, B, C, and D, whilst option 5 is if none of those are a priority. So I'm going to start the poll in a second. Here it is. I've reached 69%, which is the usual full survey. So it'll be just a 5-second and I'll close the survey. All right. So here are the results. 44% identify how easy is it to get medical care in the evenings, on weekends or holidays without going to emergency as a priority. 56% for question B about contacting, being able to contact someone to get advice about chronic condition between GP visits. 67% for calling a regular GP practice with a medical concern, being able to receive an answer the same day. And about a third identify receiving help if you felt emotionally distressed as a priority. And again, none of those questions being a priority. Excellent. The fourth one is affordability and ability to pay. That's the fourth dimension. It relates to economic capacity of people to spend resources and time to use appropriate services, and is of course of a variability in terms of being an issue in different contexts, depending on the coverage of public services, but also in terms of coverage within practices of all the services that are provided. So the three questions that were achieving more consensus for this one were: first, during the past year, was there a time when you had a medical problem but did not visit a doctor because of the cost? The second one is: during the past year, was there a time when you skipped a medical test, treatment, or follow-up that was recommended because of the cost? And the third one is about skipping either a test, treatment, or follow-up, prescription, medication, or doses, or a doctor visit due to cost. So they're all about avoidance of care, either A, more specifically for a medical problem, B, for a test, treatment, or follow-up, or C, as more of an all-encompassing question capturing those different aspects for 55-year and older people. So as for the others, this is the polling questions. So I will start the poll in a second. And here it is. All right, we've reached the maximum responses, and here are the results. So 44% identify skipping a medical consultation as a priority. 56% skipped a recommended test or treatment, and 44% skipping either a test or treatment, a prescription medication or doses, or a doctor visit. So it's a bit more evenly split or distributed for the affordability questions. Finally, the last dimension is appropriateness and ability to engage. This is probably, as mentioned in a previous webinar, the one that is the most outside the box. Very often people put appropriateness or quality of care outside of the access domain. But really, we are including it because to us it denotes the fit between services and clients' need, its timeliness, the amount of care spent in assessing health problems and determining the correct treatment, and the technical and interpersonal quality of the services provided. And from the appropriateness perspective, what we want to identify is the extent to which patients might access care, but is it care that really can answer their problems? And from the ability perspective, are all different types of patients able to engage in their care in a way that would maximize their obtention of care for all of their needs and problems? And we all know that there are vulnerable populations that could be discriminated against with regards to being prescribed the appropriate medication or referred to a specialist appropriately. but also we know that many of the vulnerable population would have difficulty to engage appropriately with providers to really ensure that what they've accessed is actually able to answer their problems. We would have a very partial view of accessibility if we would not consider the fact that systematically some people are not prescribed the appropriate treatment or cannot engage appropriately and in the end do not benefit from the care or the type of care that they can access. The 4 questions that were identified there, and I do want to reflect on the fact that there was many appropriateness questions in the Commonwealth Fund survey that could be seen as relating to access. And there was quite a strong consensus on 4 of these, and therefore it was very helpful to do that consultation so that we narrow down what we have to look into in terms of quantitative analysis. So those 4 questions are, how often does the medical staff see no important information about your medical history? The second one, did you receive conflicting information from different healthcare professionals? The third one, after your visit in the hospital ED, did your usual place of care seem up to date? And the fourth one is, how often does your regular doctor or someone in your doctor's practice help coordinate or arrange the care you receive from other professionals? And that relates to what many would consider integrated care and access to, appropriately integrated care. So the first one, knowing about your medical history. The second one about conflicting information from different professionals. The third one about the usual place of care being up to date about what happened in the ED and or emergency department. And the fourth one, someone in the doctor's practice coordinating all of the care received from other professionals. So like for the others, this is the poll. There is 4 questions options, and the 5th one is if none of those questions are important. So I'll start the survey or poll in a second. Here it is. Maybe another 10 seconds. Excellent. So here are the results. 44% for knowing about medical history, a third for receiving conflicting information, 44% for usual place of care being informed about emergency department episodes, and 2/3 with regards to someone helping coordinate the care received from various professionals. And again, none identifying none of those questions as important. Excellent. That completes this section of the presentation. Before I take some questions or comments, I just want to reflect on the fact that there were other outcomes from the LIPS consultation that we did. In general, a broader definition of primary care was suggested in some of the comments that we received, so that we really consider as much as we can other healthcare professionals than general practitioners, and consider non-medical primary care. Of course, because we're using an existing survey, we really have to work with the questions that we have at the moment, and might not be able to entirely address this, but it's going to be part of what we look at, ensuring that when a question is broader, we could use it. The characteristics of patients that were identified as being most important were income, emotional distress, education, age, chronic conditions, and speaking French and English in the Canadian context. Other variables that were important were to analyze as part of this analysis were the number of doctors that are seen, the use of hospital emergency department, not being able to pay medical bills, and visiting the emergency department for conditions that could be treated by the usual doctors. And those can be complementary analysis that we perform. So I don't know if it's an appropriate time to maybe take some reactions from the votes that we did. Are there any pending questions, Sarah?
Also, a question from Courtney in Alberta. She's asking, are there any indicators of Aboriginal statuses in Canadian version of the survey?
Yes, there is in Canada and Australia. No, sorry, there is in Australia. And Lisa, correct me, but I think that in Canada, it's not asked. Am I right? Oops, I think we have a connection problem. Is the Aboriginal question both in Canada and Australia?
Jan Willem is saying yes,
okay,
but small.
Yes, but I think that it's very small samples, and we will explore that. But for obvious reasons, we can't compare it with other countries, so it's going to be a different analysis. But the information can be provided to the LIPS anyway, even if we can't, do the full quantitative modeling using Aboriginality. Good?
Yes.
Excellent. Anyway, if there are other questions, please interrupt me. So we will write a brief on this process of question mapping and the outcomes of the LIPS prioritization. So you'll be able to refer to that. So we aim at circulating that brief summary of this process over the next few weeks. And now we'll venture into analyzing a select number of questions following this prioritization. I do want to say that we also have to consider the descriptive statistics, in terms of number of missings, variation between countries, etc., in the analysis. So there might be some questions that have been prioritized by this process that will end up not being usable, but we'll be transparent about that. So those are the next stages for us. And we hope to be able to do another webinar with the actual descriptive results to inform the LIPS about what we're finding in the quantitative analysis in a few weeks as well. So again, there will be a return to you coming from this analysis. We will also start with case studies that are the second component. And as we move along analyzing the quantitative questions, we will inform the qualitative component so that the questions we're asking experts from different countries as part of the case studies are actually informed by the quantitative analysis that we're finding, so that they can react to this. So the qualitative component, and Ricky Lane and Grant Russell can add something, and answer your questions as well. That's how it fits with the quantitative component. You can see here on this slide that the quantitative component, or the component one, is the analysis of surveys we just talked about, and we're basing it on your priorities and descriptive statistics. The qualitative component, or component two, will be interviews with experts, stakeholders across jurisdictions. But there's something else that we're doing that kind of links those together as well, and it's that we're currently working on description about organization of primary care in the selected countries. And this will be circulated to you as a brief as well, so that you can better understand how primary care is organized in the Netherlands or England on top of Canada and Australia. And therefore it also fits into your understanding of what can be done to improve care or access to care for vulnerable populations. And to do this, we're using a survey called the Qualico PC survey, PC for primary care. So it's quality and cost in primary care. That was done in more than 30 countries, and it covers the Commonwealth Fund countries. And we're also using the Commonwealth Fund survey of providers to do that on top of country profiles that we're finding and research articles that we're finding in the literature. So we will write brief case studies and description of organizations of primary care in these different jurisdictions. And this informs our understanding of the quantitative analysis of the questions we have prioritized with you and will analyze, as well as supporting the qualitative interviews that we're doing with experts. I don't know if Grant or Ricky want to add something at this moment, and if there are any questions.
I will just talk to it. So look, as Jean-Fred said, it's in a sense that the qualitative project, which is going to be based on key informant interviews within the sample of the Commonwealth Fund nations in which we have data. So we're hoping to speak with policymakers, key health professionals within professional organisations, some academics, and hopefully some community representatives. And we're going to gather gather information by interviews and document analysis, and it's going to be conducted, our intent, in English and French. We won't be making Ricky speak French, but we've got people in Canada who are working on Project 3 as well. So in a sense, the way that it'll work is that the data and the comparative data between countries will be available to inform this process. And so we're going to seek from the individuals questions like, how does the system work for access for vulnerable individuals in the country? Assuming that there is a performance gap, particularly high or low to other countries, we want to ask people why that may be the case. Try and get some information as to whether they believe that there's high or low performing regions within their country or programs that are making a difference. And also, and I think that this is alluded to by one of the questions in the webinar, is whether there's key system components that just have been overlooked in our quantitative assessment of their performance and the reasons for that performance. So, for example, the lack of ability of the Commonwealth Fund to focus on allied health professionals may in fact be not much of an issue around access for the vulnerable in some countries, but it could be a particular one in others. So we want to see whether the gaps are in terms of the data and its analysis. So findings are going to be provided in case studies of nations, sort of under the broad heading of how does such and such a nation deal with issues of access to the vulnerable, and a cross-case analysis between the countries of why the variations exist and what can be learnt from those variations that can particularly inform policy making within regions within our LIPs. So that in a nutshell is what we're hoping to do. We're keen to get the quantitative data to inform this work, and hopefully be able to get this pretty much completed not much into the second half of the year. And as before, we'll be sharing results with the LIPs, and hoping that it can help just provide some insights at a regional level into some of the unanticipated aspects of access to vulnerable individuals. So that's all I was going to say.
Excellent. Thank you, Grant. So, Sarah, do you want to give me back the control? Can you see my screen?
Yes.
Excellent. So, any questions? But before we take maybe some questions, we will evaluate this webinar. You'll receive an email to and do provide us with feedback. It's the first time we did it this way, and I hope that it was useful. But if there are some questions, I think we can take just a bit more time. Questions or reactions? No, that's good.
I think it is. There's no question or hand raised.
Excellent. Very good. Well, thank you very much then. Again, I hope it was really useful. It was certainly useful for us to receive your input. And as I said, we're going to write a brief summarizing all this and the result of the process. So you'll be able to reflect with other members of the LIPS about it. And as soon as we can, we're going to engage with you in looking at the data and sharing it with the qualitative components so that we move forward with this.
Oh.
Oops, I was muted suddenly.
Yeah, sorry, it's my fault.
Okay. Oh, that's fine. Excellent. Well, thank you very much, everyone, and have a good evening or a good day, depending on where you are in Australia or Canada.
Thank you, Jean-Frédéric and Grant.
Thanks, Jean-Fred, and thank you, Sarah, for organising, and Jean-Fred for showing us a new way into sharing information across the world.
Have a nice day or evening.
No,
Thank you. Bye.
Thank you for your leadership, Sarah. Thank you.
No